good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome back to another episode of very educative lectures for you. Today is a very good day and is also the birthday of our President, Professor Yoko Kato. So I wish her a very happy birthday. So we'll start today's proceedings. The speaker for the first session of today is our honored guest from Turkey, Professor Abuzer Gungur. He is the Associate Professor at Department of Neurosurgery, Bakırköy Research and Training Hospital for Psychiatry, Neurology and Neurosurgery. And he is also the Director of Microneurosurgery Laboratory at Yeditepe University, Istanbul, Turkey. He was a former fellow of the prestigious Rotten Laboratory and is a noted author with several publications in various peer-reviewed journals. He is also an invited faculty to various conferences and workshops organized worldwide. We are extremely honored to have him today at our webinars, and today we'll be talking about the importance of white matter anatomy of the cerebrum in neurosurgery. The speaker for the second session of today is a young neurosurgeon from India, Dr. Venkat Koyalmandam. Dr. Venkat, working as an associate professor neurosurgery, Sri Venkateshwara Institute of Medical Science, SWIMS, Tirupati, India. He is very active academically, for which he has been rewarded with several honors for his outstanding contribution to neurosurgery. We are extremely honored to have him today at our webinars, and he will be talking about prospective validation of newly proposed criteria for the diagnosis of intracranial tuberculoma. The chair for the first session of today's webinar is our honored guest from Brazil, Professor Guilherme Ribas. He is one of the most famous faces in Brazil who is a master of white matter anatomy. He is a full professor at the Albert Einstein School of Medicine as well as professor of neurosurgery at the University of Sao Paulo. He was appointed professor of clinical neurosurgery at the Department of Neurosurgery at the University of Virginia. He has published landmark neuroanatomy papers in various leading neurosurgery journals. We are extremely grateful to him for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from India, Professor V.G. Ramesh. Professor Ramesh is a professor in neurosurgery and head of Department of Neurosurgery at the Chettinad Super Specialty Hospital and Research Institute of Chettinad Academy of Research and Education, Chennai, India. He is also a visiting professor at the Tamil Nadu Dr. MGR Medical University. He was a former professor in neurosurgery at the Institute of Neurology, Madras Medical College, Chennai. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. We are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. And with that introduction, I would like to hand over this podium to our first chair, Professor Guilherme Ribas.
Okay, well, thanks for the this opportunity to join you. And maybe it's going to be repeated, but I think it's very appropriate to start remembering some historical landmarks. Fiber dissection became possible only when it was possible to harden the brain, of course. And in this direction, Raymond Vissens was the pioneer. In the 17th century, he was able to dissect the brain, and he was the first one to show the corona radiata in the internal capsule fibers. About 100 years after, in the 18th century, Johann Heil was the first one who described the alcohol method of fixation. And since Vissen and Heil, many neuroanatomists describe most of the fiber of the fiber systems of the brain, but a major step was given in 1935 when Joseph Klinger described this method of freezing the brain before doing dissections that I think is going to be repeated here. And now in the microneurosurgical era, Professor Yassergill himself was in touch with Klinger and did study on the beautiful specimens that he had dissected. And subsequently, he motivated Ugo Ture from Istanbul, who became a master in this technique and popularized it internationally through hands-on courses and through many lectures. The laboratory practice of white matter fiber dissection is currently a must in neurosurgery education and training. So I think it's very appropriate that to start with a lecture in this topic. I'm really looking forward. Thank you very much again for this opportunity to join you.
Thank you very much, Professor. It is an honor to be introduced by you. Okay, today I will talk about the white matter tracts of the cerebrum and in basic information what white matter tracts located in the cerebrum. And I want to show some cases how this white matter, how this information affect my practice. I have no conflict of interest, and as you know, under the cortical surface, there is a complex white matter thorax. It used to be known around 100 years ago. There were only some eloquent areas, but now we know there's no non-eloquent areas in the brain. For example, in this article, these areas are only related with the language, not in only the dominant hemisphere, but also non-dominant hemisphere. And how we describe these eloquent areas and white matter thorax in preoperatively, we can use imaging methods like functional MRIs and tractography, and intraoperatively we can use electrical stimulation. But can we trust the tractography, preoperative tractography? Somebody thought about that and did a study, and he sent 14 white matter bundles data to the 42 different groups, and they were the same tracks did by different groups. You can see they can change if individually, and also you can see other white matter tracks, optic radiation, corticospinal tracks. Yes, it can change, depends on who is doing the tractography. But these are the only methods we can use preoperatively. But if you know the white matter thorax, anatomy of the white matter thorax of the cerebrum, you can do this tractography by yourself, and I think this is the best method for me. And why are we doing this? Because we are operating brains and reaching some regions, and we should know which white matter thorax related with this approach. Which methods are we using? Also, Professor Libas talk about that, the Klinkler method. You can see the white matter thorax and translamination to show the relationship of the white matter thorax with the ventricles, and also tractography. And recently we did a 3D models of all these white matter thorax. You can reach in neurosurgical atlas. As you see, also these are labeled in the neurosurgical atlas. You can open and see all white matter thorax in detail, also brainstem and cerebellum. These are new things for us. We were working only 2D and 3D, but now we can do the 3D models in development in technology. If you want to know the localization of the white matter thorax, you must know its relation with the cortical surface and the ventricle. And also you must know the localization of the ventricle. The frontal horn corresponding the pars triangularis, pars opercularis, the body corresponding the inferior part of the placental and postantral gyri, atrium corresponding supramarginal and angular gyrus and anterior part of the occipital horn, and the temporal horn corresponding the middle temporal gyrus. And it is covered by the white matter thorax. As you see, our 3D models of the cortical surface and the medial surface, you can see the corpus callosum and cingulate sulcus, parieto-occipital fissure, and the calcarean fissure, and septum pellucidum and the fornix. When we started decortication, the first fibers appears as a U fibers connecting neighbor gyra. As you see, all cortex covered by these U fibers. And after removing, we are looking from the lateral surface. After removing the U fibers in the frontal and parietal lobes, SLF2 and SLF3 are appeared. SLF2 connects the angular gyrus to the pars triangularis, and SLF3 connect the supramarginal gyrus to the anterior part of the inferior frontal gyrus. And SLF3 is more related with the language, and if there is a defect in dominant area in this thorax, special hemineglect, Gershman syndrome, and dysarthry can be seen. And you can see their relation with the cortex. The yellow one is SLF3 and the other one is SLF2, and the relation with the ventricle. They are located superlateral to the frontal horn and body. We are looking from the superior. You can see the superior longitudinal fascicle tree located above the insula, and the superior longitudinal fascicle 2. And also the relationship from the superior cortical relationship. And also you can see superior longitudinal fascicle 3 and 2. Superior longitudinal fascicle 3 more related with the opercula, and the superior longitudinal fascicle 3 relates with the supramarginal gyrus and middle frontal gyrus. And when we come to arcuate fasciculus, it is the most known fasciculus, and it is related with the language, and it connects the frontal lobe to the temporal lobe and covers the insula. And is there damage in the arcuate fasciculus in dominant hemisphere? Different type of aphasia and dysphasia can be seen. And you can see it's a relation with the cortical surface, pars triangularis, pars opercularis, and anterior part of the temporal gyrus. We are looking from the superior. You can see the arcuate fascicle, and its relation with the ventricles, just locates the lateral to the ventricle, and its relation with the cortical surface. And you can see its relation with the insula. The operculum was removed. And you see the arcuate covers the insula. And middle longitudinal fascicle connects the temporal pole to the superior occipital lobe and supramarginal gyrus. and it can be related with the processing the special features of the sounds. And you can see its relation with the ventricle with translamination method. And you can see its relation with the cortical surface. We are looking from the superior, you can see the middle longitudinal fascicle connect the superior temporal gyrus to the superior occipital gyrus and the supramarginal gyrus. And you can see its relation with the cortex. Also, you can see the middle longitudinal fascicle here. And we remove the cortex of the insula, and you can see inferior frontal occipital fascicle connecting the frontal lobe to the occipital lobe just above the putamen. And also you can see inferior longitudinal fascicle at the base of the temporal and occipital lobes. And if there is a damage in the front occipital fascicle, semantic paraphagy can be seen. And if there is a bilateral damage in inferior longitudinal fascicle, progressive prosopagnosia, visual agnosia, alexia can be seen. You can see the relationship with the ventricle. Inferior frontal occipital fascicle covers the lateral wall of the frontal horn and temporal horn and atrium. And the relation with the cortex, and we are looking from the superior putamen is removed. You can see the internal capsule fibers and the inferior frontal occipital fascicle connects the frontal lobe to the occipital lobe just above the crossing the insula. And the relationship the ventricles, as you see, it is located lateral to the frontal horn, atrium, and the temporal horn. And from superiorly, its relation with the cortical surface. When we look from the inferior, we can see a better view for inferior longitudinal fasciculus, just located base of the temporal and or occipital lobes, connecting the temporal and occipital lobes. As you see, it is located the inferior lateral to the atrium and temporal horn of the lateral ventricle. And you can see 3D model. This is putamen. We removed the cortical surface, cortex of the insula and inferior frontal occipital fascicle. And you can see the uncinate fasciculus connecting the frontal and temporal lobes. And also you can see inferior longitudinal fascicle here connecting the temporal anterior part of the temporal lobe to the occipital lobe. And anterior commissure, we reach the anterior commissure after removing the inferior frontal occipital fascicle and the putamen. And also you can see a globus pallidus and anterior commissure. Anterior commissure has temporal and occipital extensions, and it connects both caudate lentiform nuclei, nucleus accumbens, temporal and occipital lobes. And occipital extension covers the lateral wall of the atrium, and you can see its relationship with the cortex. We are looking from the superior. You can see the anterior commissure just located under the globus pallidus, also internal capsule, and also you can see the uncinate fascicle here, and its relationship with the cortex. Also, you can see here globus pallidus, anterior commissure, and it is temporal and occipital. extension. And also the anterior crus and the nucleus accumbens just located the medial to the anterior crus of the anterior commissure. And also optic radiation, one of the most known tracts of the cerebrum. It emerged from the thalamus, not only lateral geniculate body, and some fibers join it from the pulvinar, as you see, and forms the Merais loop at the, just anterior to the temporal horn of the lateral ventricle, and goes backwards to the occipital, to the calcarine cortex. And if there is a damage in optic radiation, different kind of visual deficits can be seen. And you can see its relationship with the ventricle. It covers lateral and anterior wall of the temporal horn and inferior part of the atrium and the occipital horn. As you see, this is relation with the temporal horn and the atrium and the cortex, occipital lobe, calcarine cortex. We are looking for superior. After emerging from the lateral geniculate body, it goes backwards to the occipital lobe, and it is in relation with the ventricles, and it is in relation with the cortex and the occipital lobe and the calcarine cortex. We are looking from the inferior side. These fibers are the most inferior part of the optic radiation, and at the base of the atrium and the temporal horn, there is still some optic radiation fibers. As you see, this is still optic radiation fibers, and at the base of the temporal horn and the atrium of the lateral ventricle. And with 3D models of the MR image, and this is relation with the cortex. And you can see the Merais loop here emerging from the lateral geniculate body and goes to the occipital lobe. We are looking from the medial surface of the cerebrum after decortication and removing the U fibers. Just under the cingulate gyrus, we can find the cingulum connects to subcallosal cortex to the anterior part of the hippocampal gyrus, and just superior to the superior longitudinal fascicle 1, it connects the precunose and superior frontal gyrus. And as you know, the cingulum is the main part of the limbic system, and if there's a damage in these fibers and the cortex, limbic functions can be deteriorated, and autonomic phenomenon, urinary incontinence, behavioral change can be seen. You can see the relationship with the ventricle, the blue one, superior longitudinal fascicle 1, and the other one is the purple one, is the cingulum, connects the temporal lobes to the frontal horn, just as arcuate fascicle in the lateral surface of the hemisphere. We are looking from superior. You can see the superior longitudinal fascicle 1 and the cingulum just located above the corpus callosum, and also these are callosal fibers. And the relation with the ventricles, they are located superior to the atrium and the frontal head of the lateral ventricle. And this is the 3D model of the hemisphere. We are looking from the medial surface, and you can see the cingulum and the superlongitudinal one. As I said before, you can reach these models in neurosurgical atlas. And main commissural fibers of the cerebrum as the corpus callosum. We are looking still the medial side of the hemisphere. You can see the corpus callosum, and it connects the most part of the cerebrum. And if there is a damage of the corpus callosum, some symptoms can be seen. Depends on the areas which it connects. For example, if there is a damage in the splenium, some visual deficits can be seen. And corpus callosum and callosal fibers has different parts. For example, forceps major connects both occipital lobes, and the forceps minor connects both frontal lobes, and also tapetal fibers, you can see here, connects the temporal lobes by covering the lateral wall of the atrium and the temporal horn of the lateral ventricle. You can see the forceps major and forceps minor and tapetal fibers of the corpus callosum. We are looking from the superior. You can see callosal fibers, just cingulum, and callosal fibers connects the superior parts of the frontal gyrus, parietal gyrus, and with tractography. And there are some parts covers the atrium. Also, these fibers called as tapetal fibers, and forceps major and forceps minor connects the frontal horn or frontal lobes. And you can see the relationship with the ventricles. As you see the callosal fibers, forceps major, forceps minor. And uncinate fascicle, I just showed before, the connects the frontal lobe to the temporal lobe, and any damage in uncinate fasciculus, emotional problems, difficulties in learning from punishment can be seen. And the fornix connects the intralimbic gyrus to the mammillary body and the septal area. And if there is a damage in fornix, there can be different kind of amnesia. We are looking from the superior. You can see the uncinate fasciculus and the fornix just locate the base of the lateral ventricle and anterior part of the atrium and medial part of the temporal horn. You can see the fornix and uncinate fasciculus and its relation with the temporal horn and the thalamus. and the dynamic radiation, which includes the optic radiation and the cortical spinal tract. It is related with the motor movements, and you can see its relation with the ventricle. And these images from our articles, which they did with my friends, and also we are doing these fiber dissection and try to understand the anatomy of the cerebrum. Lastly, we published an article about the white matter tracts of the opercula, because you know, today most of the surgeons use transopercular approach. Because of this, we try to show all white matter tracts related with the opercula. I think Transilvian approach with preserving opercula is safer. And also we published with our friends to show the some trajectories and their relation with the these trajectories, and also you know, there's approach to reach the ambient system, transtemporal, transcorridal approach, and there's different kind of approach, and we describe their relation with the white matter tracts, and also my friends doing the 3D models. And what we learned from these all studies, our approach and their relation with the white matter tracts. And what I changed in my practice, for example, there's some different kind of approach to this kind of pathologies. But if we look to white matter tracts, the transcallosal approach is looks safer than the others if we look only white matter tracts. And also there is an atrial tumor. You can reach from laterally or medially. We did this approach from transsulcal approach, but you can see the deficit of the visual deficit. Because of this, I always prefer medial approach. As you see, most of the fascicles like arcuate, optic radiation, infrafrontal occipital fascicle located the lateral surface of the hemisphere. Because of this, for this kind of lesions, medial surface can be safer. With microsurgical techniques, you can reach these kind of lesions and they can be removed. Also, there's an atrial tumor. I use percunal approach for this kind of tumor, but with Professor Uğur, he described an approach not using the percunals, just using the parietal occipital fissure. As you see, this is the atrium location and the lateral surface covered by the optic radiation, IFOF, and only forceps major callosal fibers located in the medial surface of the atrium. Because of this, we use the parietal occipital fissure to reach the atrial lesions, as you see in this slide. And with this translumination method, we can reach this area with interhemispheric approach. After dissecting interhemispheric fissure, you can describe with ultrasonography or navigation the parieto-occipital fissure, and you can reach the arterial lesions. As you see, we are using ultrasonography to describe the parieto-occipital fissure and its relation with the tumor. And there is a cavernum, arterial cavernum, and removing by parieto-occipital fissure approach. And also, you know, there are some challenging cases related with the eloquent areas like motor and somatosensorial areas. As you see, these areas covered by the all motor movements, and we describe an approach. If there is a lesions located medial to the internal and coronary radiata, can we look if we can reach by using the cingulate sulcus. After opening the interhemispheric fissure, we describe the cingulate sulcus and dissected and reach the lesions. And for example, this is a GBM, and you can see the postoperative view we used on the cingulate sulcus approach. And also there is the case, I will show the image after the video. I always prefer lateral position to use the gravity. It can be sometimes difficult to open the interhemispheric fissure with preserving vein. And after describing with ultrasound the singular sulcus, we start to dissect all singular sulcus and the marginal ramus of the singular sulcus. And deep of the marginal of the singular sulcus will reach the lesion and remove. This is the postoperative view of the operation. As you see, this is a corticospinal thorax, and the motor functional MRI showed us that these are all related with the motor area. Because of this, we choose and describe this method to interhemispheric transcingulate sulcus approach to remove this kind of tumors. And also the globus pallidus, if there is a tumor in globus pallidus, it is difficult to reach from the laterally because the lenticular cystoid arteries, and if there is a damage in lenticular cystoid arteries, they supply the internal capsule and most of the basal ganglia, and there can be hemiplegia. And also it is difficult to form the medial. You can see the corticospinal tract. What we described the method to also, we must pass some tracks, but we should choose the safest way. Because of this, we choose the which we are anterior limb of the internal capsule to reach this kind of tumor. You can see there is a globus pallidus tumor with cyst, and we are anterior limb of the internal.
Doğru gel bana doğru.
Also, the patient has palsy preoperatively. It is better now, as you see. And if we have time, I can show something about the deep brain nuclei. Mr. Roger, I think I have
Yes, you
time.
may. You may.
Okay. And also in functional neurosurgery, you must know the microsurgical anatomy of the deep brain nuclei, because to choose the best target and avoiding the side effect and understanding the side effect of your stimulation. We are looking from the laterally. After opening the removing the opercular, you are saying insula, external capsule, external capsule, as we showed the infrafronto-occipital fascicle, costocortical fibers, putamen, internal capsule, globus pallidus, anterior commissure. As you see, they are really deep structures. In this slide, you can see globus pallidus externa, globus pallidus interna, just located medial to it, and internal capsule located just medial to globus pallidus interna, and thalamus, subthalamic nucleus, red nucleus, and we are looking from the superior. After cutting the vein, we can see the thalamus, fornix, and ventricle. After removing the fornix in the right side, you can see thalamus and thalamic nuclei, and you can see the anterior thalamic nuclei, this nucleus. And after removing the thalamus, you can see this side zona incerta and subthalamic nucleus, red nucleus, and substantia nigra. And in this side, you can see the subthalamic nucleus and its relation with the internal capsule and the globus pallidus interna and the putamen. And both caudate nuclei was removed. And you can see subthalamic nucleus, red nucleus, substantia nigra, globus pallidus interna, externa, and the putamen and internal capsule, and prelemniscal radiation and optic tract. And where we did these studies, I worked in Roton laboratory in 2014 and 15. Most of these studies made in there, but now I am working with my fellows and the Professor Utu and Rashagil in Yeditepe University, still doing these dissection with my fellows, and this is our laboratory. Anybody wants to come, you're welcome. And I want to thanks Utu, Rashagil, and all my fellows. And we are waiting you to Roton Society meeting and neurosurgery course in August 2023. And a small video from our laboratory. We are still taking 3D photos with 3D models, and our medical illustrator, Eileen, is doing a good job. And the laboratory, microsurgical laboratory, is the simulation of the all operations. You can see one of my fellows doing a fiber dissection, and one of them taking photography of her dissections. And also I want to thank Professor Wotton, and I want to thank also all healthcare workers who passed in, who we lost in pandemic. One of them was the Ahmed. He was my first fellow. We lost him because of COVID. I want to him again. Thank you very much. There's any question?
Well, number one, congratulations for your very elegant, didactic, and very difficult cases. Great lecture. I wish we could have time to discuss a lot of things. The only thing I want to touch here is that when we see these lectures, we see different explanations about some, for example, segmentations of the SLF. You see differences, particularly when people talk about functions. I'm a little bit skeptical about when we're talking about small tracts, particularly small tracts. I think fiber dissection is a must in our education nowadays, but it has some methodological limitations. The same for DTI. As you showed, DTI has a very low sensitivity. And when we talk about functions, I think things get worse. You see different people talking that these small tracts have different functions. I think that even some tracts might not exist. For example, SLF1 that you showed, many people think that it doesn't exist. I think even Ugor already in the past mentioned that it doesn't exist. You didn't mention frontal Aslan tract, for example. I would like you to comment on that. So I'm a little bit skeptical about this very specific characterization of small tracts. I think we should have more reproducible studies, and we should have a different neurophysiology in the future to make sure about these functions. I think we have to take a lot of care if the structures would cause real lesions in patients. It's a doubt I have throughout these years going through along this beautiful history that you told us about.
I have the same opinion with you and with Professor Ture. You can find a lot of small tracts in the brains, and also I say SLF1. Also, it is close relation with the cingulum. We can call as a part of cingulum. Also, and superlongitudinal fascicle 2 and 3, we can accept them as a part of arcuate fasciculus because it is difficult to differentiate these fibers. But in the literature, as you know, you can give different name, but in my opinion, it is not important of the name of these tracts. You must know their eloquent areas and which fibers connect these eloquent areas, and try not to touch them.
We are joined by Professor Atul Goel. Professor Goel, any remarks from your side?
Okay, thank you very much. You know, unfortunately, I joined a little bit late and I could not hear the entire lecture, but I heard the remarks of the giant of white fibers, Dr. Ribas, and I'm very happy to see him on the screen and hear what he had to say. You see, white fiber anatomy was not at all considered. You know, when we learned brain's anatomy, it was frontal brain, parietal brain, occipital brain, motor strip, speech area, and that's it. And other things were hardly ever considered. I think this white fiber anatomy, understanding of white fibers, understanding the importance of white fibers, understanding the infrastructure, the foundation of the brain that white fibers provide, and the various functions of white fiber have completely taken the whole story of brain anatomy and brain surgery to a much greater level. Now, I want to, also make a comment that we had written one article on the subject where we had mentioned, Dr. Ribas, I want your comment also, where we had mentioned, probably for the first time in the literature, that gliomas arise from a named white fiber tract, and they grow along a named white fiber tract, and they displace the adjoining structures. They displace the adjoining tracts, and the adjoining tracts are affected by virtue of pressure and deformation and not by destruction. And also because the gliomas grow along a white fiber tract and the other fibers are displaced, you can actually identify from which white fiber tract these tumors are arising. That is one thing. And second thing is, because these tumors arise from a white fiber tract, they are confined in nature. They are having a anatomical concept of confinement, and you can develop a plane of dissection around the tumor, and you can remove these tumors, saving the tract, and remove them completely en masse. So this is what we had described in our article. So I want to know your comments, of course, from the speaker and also from Dr. Ribas. What does he think about this concept of gliomas?
Well, I fully agree with you, particularly in the sense of the tumors stay in what Yasagil calls compartments. I think they stay in compartments, and I think that they arise, as you said, related to the fibers, and they sort of follow the fibers. I agree completely in this, and I think that's what makes possible anatomical surgery. I mean, I have a little bit doubt if they don't destroy, particularly the very malignant, they might destroy some of these tracts. Now, I really agree with you. I don't know how much we can do about saving these tracts. Now, the main point I tried to make when I did my comment is that personally, I do not believe that all these tracts are this much important as we are thinking that they are now. We have, as you said, we have a lot of past surgery that went through this. I always say we have decades of anterior lobectomy that was done just to some radiation, optic radiation problems, with no memory problems, no language problems, no anomia, no a lot of things. And now we're becoming scared of these tracts, I think that at some extent it might be true, but at some extent, I don't think this is all this true. That's my main point about it. Now, coming back to your glioma surgery, I definitely agree with you. I think, and that's why I like malignant tumors more than vascular, because you can be creative. You have to know anatomy to operate on these lesions. Thanks for your comments.
Another thing, Dr. Ribas, I would like to know, if these tumors are confined, if these tumors are, they look aggressive, they look diffuse, they look infiltrative, they are massive in size many a time, and you are removing them en masse. What do you think? Personally, I want to know how much is the role of neuromonitoring, awake craniotomy, intraoperative monitoring, and all those things, if the white fiber tracts, which I agree completely, and this is the first time I'm hearing a big person, a big name in white fiber tract talking in this language. So I'm very happy to hear what you said. So I want to clearly understand from you, what is the role of neuromonitoring? What is the role of, can these things be avoided if we understand that these tumors can be removed en masse, or they are confined tumors? What is your view, Dr. Ribas?
Well, the honest answer is I don't know, because I think we still don't know. We still don't know how much this brain mapping, all this, it's going to stay. We're going to have some passive mapping in the future with some information gathered before the surgery. Now, for example, language area, we always do awake. I think it makes a lot of sense. But in the right hemisphere, for example, I'm in doubt. I'm in doubt. I usually don't do it, but I have the doubt. I'm sincere. I'm humble enough to say I'm in doubt. Now, I think these things are coming to stay. Some are going to be changed. New technology. We're going to be having new information. And about your glioma, I think the only problem is that glioma is not a tumor of the brain; it's a disease of the brain. You know, it's programmed to come back. Something is happening even outside these compartments. The more you treat these patients, the more you see tumors in the other side. The more you see tumors arising, multiple tumors. It's a disease of the brain. It's not a cancer like other parts of the body. It's completely different disease, I think.
Anyway, you know what, Dr. Raja? I
Yes,
have to compliment you on bringing Dr. Ribas on the show. If you read his books on white fiber tracts, and I'm sure our speaker must have gone through his work on white fiber tracts and his classification of internal capsule and external capsule and various things. You see, he has put, I will recommend very strongly. So all those young and senior and whoever is watching this show to read his book on white fiber anatomy. And you get some novel, fantastic, beautiful views. I think nowhere in the world those kind of views have been presented. And I'm proud to see him on the show, Raja.
Well, thank you.
Thank you very much.
Thank you. We all know Professor Ribas is a master of anatomy, neuroanatomy, and his paper about the sulci and gyri in neurosurgical focus was the most downloaded paper of that year in 2010. So there leaves no doubt regarding who our honorable chair is. Thank you very much. We are extremely grateful to both of you for this wonderful session. So I'll move on to the second chair, our very honorable guest from India, Professor V.G. Ramesh, very senior professor, and ask him to overtake this.
Good evening, Raja, Atul, my dear friend, and Dr. Professor Ribas and Professor Gungur. It is really an honor to be amongst you who share this webinar on ACNS webinar, and I am really thankful to Raja and Professor Kato for asking me to do this. The next topic is going to be on tuberculoma, which is very prevalent, at least in our part of this world. So in the 80s, early 80s, Atul also may remember, we used to operate on tuberculomas, which are giant tuberculomas, almost size of the giant meningiomas. After the advent of modern imaging technology and CT, MRI, and all that, we are able to detect these lesions much earlier. And to avoid surgery, we can put them on. We have other methods to diagnose their histology, and we used to avoid major surgery because they are detected early, and medical treatment they are disappearing. And we used to operate almost. In one of the papers published from our institute in the early 80s, gliomas, tuberculomas form the major part of intracranial space occupying lesions, even more than gliomas. In one of the papers of Professor Kalyan Raman, who was published in Neurology India, he has shown that the number of tuberculoma is nearly 50%, was 50% in early 80s. But now, hardly we operate. It is almost several years since I have operated on a tuberculoma last. So, because of this modern advancement, it has taken place. But there are so many lesions which can mimic a tuberculoma. So, Imaging alone may not be the guide to diagnose tuberculoma, and many times we may mistake other lesions like metastasis, lymphomas, and other things, high-grade gliomas, to be tuberculomas, and maybe treating in the wrong way. So I think Dr. Venkat, who is going to talk on the next, the next lecture, going to highlight on this, how to detect tuberculoma, make sure that it's only tuberculoma we are treating by various other criteria, criteria to diagnose them and treat them early with avoiding a major surgical procedure, and not to, mistreat other lesions as tuberculomas. I think I am looking forward to Dr. Venkat's lecture. I think is a bright, shining star in the horizon of neurosurgery, and I welcome Dr. Venkat to give his lecture.
Thank you very much, Professor Ramesh sir. Compared to your experience, we have very minimal experience, but whatever we found out, I would like to share, and I'll be happy to get your comments on this. First of all, I'd like to thank Dr. Raja for inviting me for this webinar, and many happy returns of the day to Professor Yoka Kato. So just now, Professor Ramesh has mentioned that tuberculomas are confused with many of the other lesions. So we know that effective anti-tuberculosis therapy is available, but still in developing countries like India, we see a lot of cases. 26,000 new cases occur globally each day, and more than 4,000 die of TB every day. And CNS tuberculosis is special in that it manifests in various other ways. It can manifest as meningitis with or without hydrocephalus, arachnoiditis, tuberculous abscess, and one of them is tuberculomas. Intracranial tuberculomas are peculiar in that even though they are rare, they can mimic any other disease in imaging. They are often misdiagnosed, they are underdiagnosed or overdiagnosed. It may lead to unnecessary ATT and side effects of ATT. And sometimes we may delay the treatment of this lesion, and sometimes unnecessary surgery is needed, thinking that it is some mass lesion or a tumor. So there are no strict criteria for diagnosis of tuberculoma till now. Most of them diagnosed by opinions, possibilities, and other pictures. CSF is often clueless because if the meningitis is not there. So we did a retrospective analysis and we published few criteria. It was a retrospective study from 2010 to 2019. All the patients operated in our institute, which are suspected as tuberculomas or which have been proven as tuberculomas post-operatively. We have included all these patients, and these patients have been divided into two groups. One group which is biopsy proven as tuberculoma, and other group which is not proven as tuberculomas. So empirical treatment given patients for tuberculomas were not included in the study. So in this retrospective study, we found out 69 patients, among which all the 69 were suspected to be tuberculomas, but only 40 turned out to be tuberculomas. Other 29 patients came out to be something else. So that means there is a very high misdiagnosis rate. So the final histopathology in the rest of the 29 cases were metastasis in 8 cases, GBM, cavernous angioma, astrocytoma, lymphoma, fungal granuloma, medulloblastoma, meningioma also in one case, and hematoma, bacterial abscess. So we can see it's a great mimic. It can mimic many lesions. So in these cases of 69 patients, gross total excision was done in 43 cases, near total excision in 9 cases, partial excision was done in 3 cases, and only biopsy was done in 14 cases. So we did sensitivity, specificity, positive predictive value, negative predictive value, and calculated diagnostic accuracy of each of the finding which was appearing as leading towards tuberculoma. And those above the 50% accuracy, diagnostic accuracy, and above the 45-degree ROC line were taken as significant. So in this study, we can see, and we took as those with more than 70% diagnostic accuracy, we took as major criteria. So ESR in that study was 76% accurate to diagnose tuberculomas, and conglomerate lesions in CT was 79%. T2 central hypointensity was in 75 patients. And more than 50% diagnostic accuracy we took as minor criteria. So these were the criteria which we named as SWIMS criteria. This is the institute where I'm working. So major criteria are the three which I have mentioned. And we have taken more than 20 mm for the diagnosis as a limit, because less than 20 mm frequently neurocysticercosis may be confusing with tuberculomas. So we have taken this 20 mm as per Dr. Vedantam Rajshekhar's previous papers. And minor criteria we have taken as presence of basal exudates or enhancement in post-contrast CT along with intraparenchymal lesion, presence of ring enhancing lesion, lipid lactate peak in MRS, out of proportion perilesional edema in MRI or CT, positive mantle skin test, past history or presence of active source of tuberculosis, and presence of multiple lesions in imaging. So after applying these criteria, there should, for diagnosis, we should have 3 major criteria or 2 major and 3 minor criteria, 1 major and 5 minor criteria, or all 7 minor criteria of these things has to be taken. So by applying these criteria retrospectively, all the 40 cases were diagnosed with tuberculomas, and all rest of the 29 cases we could exclude because they were not meeting the criteria. These are the few examples. This case, we can see there is severe edema, T2 central hypointensity, there is ring enhancement, ESR was high, lipid lactate peak was there in MRS. So 2 major and 3 minor criteria were met. So it is tuberculoma, and that is the biopsy. And another case, T2 central hypointensity is there in the small frontal lesion, and another one the posterior. And there is severe edema, there is conglomeration of lesions, and there are multiple lesions in MRI. ESR was raised. There is also disseminated tuberculosis in this patient, and there is also ring enhancement. So 3 major criteria were met along with other 4 minor criteria. So it was diagnosed as tuberculoma, and the frontal lesion was taken for biopsy because it was very superficial. And this is the biopsy which shows Langhans cells, which is very typical of tuberculoma. And this patient, after removing the frontal lesion, we continued anti-tuberculous therapy. But in spite of anti-tuberculous therapy, this occipital lesion started growing. It was causing mass effect and visual disturbances, so we had to remove that lesion also. And after removing, this is after final ATT, the patient was completely cured after ATT. This is another case of severe edema, T2 central hypointensity, and criteria were not met in this case. So the biopsy turned out to be lymphoma. Another case of severe edema, T2 central hypointensity, ring enhancement, raised DSR, positive mantle skin test was there. 2 major and 3 minor criteria were met, and it was the biopsy turned out to be tuberculoma. Another case of severe perilesional edema, T2 central T2 hypointensity, solid enhancement is there, but there is no ring enhancement. And this is the biopsy which came to be, criteria were not met, and the biopsy came out to be metastatic adenocarcinoma from lung. Another case, conglomerate skin lesion, T2 central hypointensity, severe edema, raised DSR. So 3 major criteria were met, so it was a tuberculoma. Another case of T2 central hypointensity, severe edema, conglomeration of lesions, raised DSR. There is also fever and weight loss. So 2 major and 3 minor were met, so it was tuberculoma. So the uses of the criteria were, if criteria are met, we can avoid unnecessary surgery. We can confidently give ATT. We can plan biopsy or removal of the lesion for alternative diagnosis if it is not meeting the criteria. So after doing a retrospective study, we wanted to validate this by a prospective study. So we did a prospective study and included all patients of any intracranial space occupying lesion on MRI or CT, and excluded those who were not willing to take part in the study. It was a prospective study and still going on from April 2020 to April 2023. So this is the proposed protocol for the study. If any patient of mass lesion is found in CT or MRI, we applied the criteria. If the patient has raised ICP or signs of herniation, we immediately take for surgical decompression and biopsy of the lesion. Then we can continue ATT. If there is no raised ICP, immediate signs of herniation, then we directly start ATT and follow up imaging. If criteria were not met, we do a metastatic workup, and if primary is found, we treat the primary. If primary is not found, we do early biopsy or surgery. So this is the complete protocol of the study. So in the prospective study, we included 342 patients. 24 met the criteria. 15 were operated because of various reasons, and 9 cases were started on ATT directly without doing surgery or biopsy. All 15 are reported as tuberculoma in biopsy, final histopathology, and rest of the 9 responded well to ATT. They are still under follow-up. Rifampicin resistance was not found in any of the cases. And the rest of the 318 patients, surprisingly, biopsy was not tuberculoma. So the accuracy till now was 100%. And the mean duration of ATT was 6 months, and mean duration of resolution of lesions after giving ATT was 12 months. So this is a few more cases. T2 central hypointensity, 2 similar looking lesions on the right side and left side. On the right side, there is a T2 hypointensity, severe edema, ring enhancement. ESR was high. 2 major and 4 minor criteria were met, and it was tuberculoma, and biopsy was also proven. This is another case of T2. It was hyperintense. Multiple lesions were there. MRS lipid lactate peak was there. Only 1 major and 2 minor criteria were met. The biopsy turned out to be GBM. Few more cases. This is in the motor area. So criteria were not met. It was not tuberculoma, so we didn't operate the patient. And we searched for primary, which came to be primary metastasis from lung. So another case, T2 central hypointensity, ring enhancement, perilesional edema, ESR was elevated, past history of tuberculosis was there, positive mantle skin test was there. So the criteria were met, and it turned out to be tuberculoma. So this is after ATT. So this is a tale from Panchatantra, in which the 4 blind men were asked to tell about how an elephant looks. So one person says elephant is like a big snake. Another person says, after touching it, the leg, he says it's a tree stump. Another person says, no, elephant is like a sheath of leather. Another person says it's a furry mouse. So if you see the big picture combining all the features, then we can give a proper description of an elephant. Similarly, I think we propose that whenever we have a diagnostic suspicion of tuberculoma, we suggest to apply these criteria. And by applying the criteria, till now, we could diagnose all the cases of suspected patients. And when the criteria were not met, early biopsy should not be delayed, because we can delay the diagnosis of some curable lesions. And we suggest metastasis workup should be done whenever the criteria was not met, because metastasis was frequently confused as tuberculomas. Surgery decreases the duration of ATT and helps in early resolution of lesions. And duration of ATT should be based on radiologic resolution of the lesion, not merely on duration. So I thank you very much. I thank our Professor Ramesh Chandra sir and Dr. B. Prasad sir. These are all the acknowledgements. Our other colleagues who helped in the study. Thank you so much.
Congratulations, Dr. Venkat. Nice study, and you have your criteria, major criteria and minor criteria are very nice. And this is a new, it's a new thinking process. I think it will go a long way in narrowing down the diagnosis of tuberculoma and proper treatment. I have only, a few comments to make. One is the criteria, minor criteria mentioned, fever, weight loss, etc. As far as I am concerned, I have seen quite a few tuberculomata, but none of them had any of the constitutional symptoms. And also, you mentioned about basal exudates, presence of basal exudates in tuberculoma, in addition to the mass lesion. But actually, the pathogenesis, you say the pathogenesis of tuberculoma is totally different from meningitis. mean, actually, it has been established that people with immune status is low, they go into meningitis, get the meningitis, and those who have high immunity, they get the tuberculoma. I mean, high cellular, cell-mediated immunity. So these two criteria, I am little skeptical. Probably you can add some criteria like PCR, probably PCR for tuberculosis, or this gene expert. These can be included probably if it is possible. I think these are things I think. Otherwise, it's a very nice paper. Probably it needs validation by other centers also. Probably can recruit other centers to join your study and validate your criteria. Good,
Thank you, sir.
Thank you.
Thank you for the comments. Regarding first comment, the fever and weight loss, we also found the same finding, and it was not included as a minor criteria, sir. If you can see the criteria, the fever and weight loss, the accuracy was very low. It was less than 50%. So we did not include that in one of the any of the criteria. And second thing, you said basal exudates. You are right. You have rightly pointed out. So basal exudates also we found in very, very few patients. That's why we took it as a minor criteria. Sometimes we found basal exudates along with tuberculomas, but it was a very rare finding. So it was taken as a minor criteria. And third thing regarding PCR for tuberculosis, the CSF, if we do lumbar puncture, it was very low sensitivity in case of tuberculoma, as you have said. By the time we diagnose tuberculoma, the patient CSF is almost, there are no bacilli in that. So that's why probably we will look into that also, sir.
Thank you, Venkat. Professor Goel, any comments from your side?
Hello,
Yeah.
sir. Good evening.
Yes.
How are you, sir?
Very good. Nice to hear you in talking like a very, very big expert. Venkat, I'm happy to hear from you. That is one thing. For sure, I wish you all the best. I want to hear more of you and more from you. Okay, Venkat?
Thank you, sir.
That is one thing. And second thing which Dr. Ramesh mentioned already, and that is a very, very important thing in understanding tuberculomas and tuberculous meningitis. Like tuberculoma is a manifestation of good immunity of the body. If the body has good immunity, there will be tuberculoma formation. If the body does not have good immunity, there will be meningitis and basal exudates and infarcts and things like that. So tuberculoma in general, they might become large and sometimes they become huge and sometimes, they can look very dangerous. But tuberculoma is a manifestation of a good immunity of the body. That is one point. Second thing is sometimes there is an issue, like you see a large lesion, large tuberculoma, large lesion, enhancing lesion with quite an extensive edema. And the patient is absolutely all right. Patient is running around, jumping without any much symptoms. So I usually like to say, lesion bad, patient good, it is tuberculoma. Lesion small and lesion not so big, but patient bad, it is an aggressive tumor and it is a malignancy. So lesion good, patient bad. So patient's clinical issues are also quite relevant when you are going to examine and identify whether it is tuberculoma, because you have to identify before operation whether you need a biopsy or not, whether you need intervention or not. The other thing that is also very important, I'm not sure if you mentioned about it, is the presence of edema around tuberculoma. So sometimes the tuberculoma may be small or moderate size and there is extensive edema in the whole brain or half the brain or quite a bit of brain. So presence of edema, and the patient is all right despite the edema and despite the features. So edema actually is a nature's protective maneuvering. Like edema is not the pathology. Tuberculoma is the pathology. So edema is an attempt by nature to limit the tuberculoma or limit the infection in one small confinement. So edema actually is like inflammation. When there is a throat infection, there is fever and all those things. Those are secondary and they are protective. Similarly, edema in the situation, extensive edema around the enhancing lesion is a nature's protection, and one of the ways to identify that this is a tuberculoma, because infection, even brain abscess, the edema may be quite aggressive. So presence of edema is also an indicator that you are dealing with a tuberculoma. And extensive edema, despite being no symptoms. You see, if it is a malignancy and there is edema, the symptoms will be prominent. But in tuberculoma, the symptoms are not so prominent. So I have a feeling that tuberculoma, particularly in our part of the world, we have to identify, and your presentation will give novel information to all those who are listening to you. But we have to also include some clinical features that what Dr. Ramesh mentioned about immunity of the person and presence. Also, in some cases, some children in particular who are having exudates, as you mentioned, exudates and infarcts and tuberculomas, those kind of situation is a fulminant kind of a tuberculosis. When they have fulminant tuberculosis, you can have both these things. And then the meningitis is more aggressive. But in adults or in more older population, you will have either meningitis or tuberculoma. Both together are not so much common. What do you have to say, Venkat? Tell me, I want to hear from you.
We also didn't find, sir. When tuberculoma is there, basal exudates was very rare. And the accuracy of that feature was very low. And regarding edema out of proportion, we also agree with you, and it was included as one of the minor criteria for diagnosis of tuberculosis.
Not major, huh?
But because many other lesions can still have severe edema, like GBM metastasis. So when we calculate the diagnostic accuracy, the positive predictive value was very less, sir. But negative predictive value was very high. If edema is not there, then it's definitely mostly not tuberculoma. So the negative predictive value was very high, but positive predictive value was low because other lesions can also have such a severe edema, like GBM or metastasis.
What about clinical features?
Sir, as you rightly pointed out, many of the patients have no symptoms or very mild symptoms. So clinically, I don't know what can be included for. If you can suggest, we will include that.
No, you think
patient
about
is
it.
walking around, you said, and they'll have mild headache, or incidentally it will be found in MRI many times. So clinically, how relevant, I don't know, sir.
So you think about it and include some clinical features also in your study, okay? And there was one more very interesting article by Dr. Vengsarkar, and he identified features of tuberculomas, and that article was published with a cover page illustration of tuberculoma in Journal of Neurosurgery. I think you should refer that article. Dr. U.S. Vengsarkar was the first author, and there was a large tuberculoma, and he had removed it completely en masse kind of thing. So, and in that article, he has discussed about radiological and clinical features of tuberculoma. I think it may help if you read that article. About 20 years ago, he had written, 25 years ago, maybe.
Sure, sir. Thank you, sir.
Thank you, Professor Goel, for these wonderful comments. Venkat, you must go for an external validation of this study.
Sure, sir. We should
ask for your colleagues. I don't know how common is it is in the West, but when you go on a global scale, you must add ethnicity also as one of the minor criteria, because it's more common in Asian population.
Developing nations like Africa, South America, and other parts of South Asia, where it is more common. That is a point very well taken.
Yes, Professor Ribas is still with us. Professor Ribas, would you like to make some comments?
Yes, I just want to comment. Congratulations. I was very curious to see this. In Brazil, we have a little bit. We used to have more. And as Professor Aitul said, if you don't have a good immunology versus having a good immunology, you can have a tuberculoma or a meningitis. We just think about this. But the parallel we have here in Brazil is with central nervous system cysticercosis. We have much of these, like in Peru, they have very much also. we don't have this much tuberculomas, but we had a few in my residence time. I remember a couple of them. And what is good for us is that a very good lesion to be operated on. It really looks like a cavernoma surgery. And I think this is very challenging. It's a good opportunity for young neurosurgeons to operate on these lesions. But congratulations, I did learn very much in your lecture, but thank you.
Thank you. Thank you.
Thank you very much. Dr. Khabibullah is joined us from Nagoya, right? Khabibullah, would you like to say anything?
First of all, thank you for your excellent presentation. I think as I am a young neurosurgeon, and such kind of tuberculoma case is too rare in my country, and I have never seen such case even observed, or even it's the first time for me to see this excellent presentation. I think maybe in the future, when I will have to deal with this, I think this presentation will play a much more important role in some dealing with this kind of issues. Thank you, Doctor. Thank you.
Thank you, Khabibullah, for joining today. Hope you have a very nice time in Nagoya. So we'll move back to our chair for the concluding remarks, and then we'll wind up. Professor Ramesh.
Yeah, I think most of the things Atul has covered on my behalf. See, I mean, it's a very nice work, and I think you should, do further this thing, progress on this, and probably go for external validation. And I think this will get established as one of the, tools for the diagnosis of tuberculoma of the brain. I think it's an excellent work. Congratulations again.
Thank you, sir.
Thank you very much, sir. So I'll wind this up officially now on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaita. I would like to thank both speakers of today, Professor Abhizar Gungor and Dr. Venkat Koyalmantam, as well as the chairs, Professor Guillermo Ribas and Professor V.G. Ramesh, as well as our elite panelists, Professor Atul Goel and others. And we are extremely thankful to everybody others of the panelists as attendees who joined us. I would like to express my sincere thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And as of now, we have around 575 people live on YouTube, WeChat, and Zoom. So until we all meet on 12th of November, it is bye-bye from all of us. Thank you very much for joining.